Hi everyone, I am Kevin Cobty. I'm working on this case with Bethany Leach. We're both fourth year med students at Wayne, um, presenting on a patient that we had during our hematology rotation at Henry Ford. So for the HPI and ROS, HPI, this is a 76-year-old male. He presented to us at Henry Ford from an outside hospital for a higher level of care for renal evaluation. He was being seen at the outside hospital for symptoms of lethargy and anemia that was getting worse. When he arrived to Henry Ford with us, he was complaining of symptoms like epistaxis and hematuria and weakness, and these have been going on for about a week before arriving to Henry Ford here. And for the ROS, in general, for the general, it was positive for lethargy and yellowing of the eyes. Cardiac, he was dyspneic on exertion. GU, he was complaining of hematuria. And lastly, for the skin, he was complaining that his skin was getting more yellow and jaundiced. For the history, his past medical history, he does have atrial fibrillation, hypertension, and hyperlipidemia. Past surgical histories, nothing recent, but he did get a mitral and aortic valve replacements in 1995. No known drug allergies. Medications include warfarin, metoprolol, digoxin, furosemide, amlodipine, and simvastatin. No significant family history and no significant social history. In terms of the vitals, labs, and orders, his vitals were relatively stable. He was hypertensive at 155/71, but otherwise fairly normal. In terms of the LDH, it was really pretty elevated at 3,395. Haptoglobin was less than 30. Total bili was 7.5. Direct bili was 1.8. AST elevated at 161, and ALT fairly normal at 44. The reticulocyte count percentage was high at 7.4%, and the absolute count was high at 196.1. I'll go over to the right a little bit on this diagram. That's in a white color. So sodium was 136, potassium 4.4, chloride 101, and bicarb 27. As you can see here, BUN was pretty high at 150, and creatinine also high at 7.08. Glucose at 149, hemoglobin 6.9, and hematocrit at 21, so pretty anemic here. White blood cell count is 9.1, and the platelets were 177. And then I'll go back down to the bottom here. The peripheral smear, it did show signs of schistocytes. Schistocytes were seen, and then it showed signs of normocytic, normochromic anemia. And one last thing is that there was a renal biopsy done at the outside hospital. We didn't have results for the biopsy for several days here, so as we're working up this patient, this was kind of like pending as well for us. So for the differential diagnosis for this patient, he's got a couple of things going on here, right? Like the hemolysis, acute kidney injury or renal failure, as well as anemia. So pretty high on our list right now was atypical HUS. The triad being MAHA, microangiopathic hemolytic anemia. He did seem to have hemolysis. He did also definitely have the AKI picture, but he was not thrombocytopenic, so this wasn't, we couldn't just he didn't fit the full triad. Other things include warfarin-induced bleeding. He was on warfarin for pretty chronically, but this would definitely, if it's not the cause for the bleeding, it definitely didn't help. TTP was definitely on the list as well. Again, he was not thrombocytopenic though, although there were schistocytes seen. Autoimmune hemolytic anemia is definitely on the table as well. Again, anemia is definitely present. It could be autoimmune. And then the last thing is uremic bleeding from renal failure. So further lab testing and renal biopsy report. So we finally got the biopsy report after a few days, but I'll start with this. The Coombs test was negative actually. So this did not support autoimmune etiologies for the hemolysis and the anemia. Renal biopsy, so the results. So it didn't show any signs of fibrin thrombi, endothelial swelling, or mesangiolitis, or any vascular changes that would be consistent with TTP or HUS. So the renal biopsy actually did not support HUS. And then the echocardiogram findings, So, we knew that this patient had a history of the valve replacement in 1995. So the echo was done to kind of evaluate these. Upon evaluating the aortic valve, we saw that it had significant stenosis, as well as a suggestion of a mild perivalvular leak. The mitral valve was similarly also stenosed, significantly stenosed. So, cardiology was already on the case. So, these findings definitely gave us more of a clue as to why this patient is having hemolytic anemia. So the final diagnosis was valve-induced hemolysis, which was very supported by the echocardiogram findings. But I thought this case was very, unique in the sense that there's definitely many different things we can learn here. There's such a broad differential for hemolysis. We worked up to try to come up with many different etiologies. Nephrology was also on board because we actually suspected that HUS was the most likely culprit, at least in the very beginning. So a lot of different services involved, a very broad differential. I hope there was some learning from this case. Thank you for listening.